It's an absolute pleasure to be here. And again, this does cover the entire Americas. I'm from Montreal, the Latin part of Canada. I'm going to talk a little bit about Barrett's, whether or not it's a real problem. I'll start off by saying Barrett's itself is not a problem. Dysplasia is the problem. There, we can stop the talk. So this is a Barrett's esophagus. This is a slippery slope from gastroesophageal reflux down to malignancy. As you can see, GERD is extremely common, depending on which population you look at. The more obesity, the greater their rate of gastroesophageal reflux disease, between 30 and 40% of most major populations. Barrett's itself develops in approximately 5 to 10% of that patient population. It's extremely common. Then, as the cells change furthermore into more dysplastic, either low-grade dysplasia, high-grade dysplasia, ultimately to malignancy. We have to recognize that Barrett's itself is a normal protective mechanism by the body in order to reduce the deleterious effects of acid reflux and acid damage and burning to the distal esophagus. So it's in itself, it's a protective mechanism by the body. However, the progression from Barrett's to dysplasia is a concern. So we have to recognize that rate has actually decreased. We used to remember when we all were in medical school, it was around 1%. The more recent data from their excellent data epidemiologic group from Sweden demonstrates only around 0.1%, as we recognize more and more patients do have Barrett's. So we don't really want to treat it here, because if we treat it here, we're treating way too many patients. This is, I mean, that's 1 to 2% of the population. Although Medtronic will love for us to treat all those patients, we don't actually need to treat them with invasive techniques at the level of Barrett's. What we need to get involved in is at the one that becomes dysplastic. And there's more and more data to say that maybe low-grade dysplasia is where we need to get involved as well. However, we have to recognize that this is a relatively rare beast. Really, we're mostly seeing high-grade dysplasia or early malignancy. So what were the options for management of dysplastic Barrett's? Up until 20 years ago, it was pretty much simple. Wait until they develop cancer, and if they do, and operate on them, or just operate on them if they have a dysplastic or high-grade dysplasia. Over the past 20 years, there's been a cornucopia of endoscopic therapies, both ablative and resectional. We'll talk about those right now. So this is the first kid on the block. Everyone's familiar with this, photodynamic therapy. Overholt presented a bunch of series starting in the mid-90s. In which they used photodynamic therapy with a centralizing catheter. It reduced the rate of progression to malignancy of patients with high-grade dysplasia by approximately half. The problem with it causes severe strictures and also severe photosensitivity. In fact, people used to have to go out with the sombreros and sunglasses after getting this because of the severe photosensitivity they would have. So that has largely been replaced. There's a few centers that use it with a bare catheter, but pretty much largely have been replaced with radiofrequency ablation. This is a gentleman from my practice. He's a 56-year-old French-Canadian. Ironically, his name is Barrett, which is a very common name in Quebec, and also the name of our health minister. But he had a 5-centimeter Barrett's esophagus with multifocal high-grade dysplasia. You can see on narrowband imaging here. We used a radiofrequency ablation. Now the one that's being most commonly used is from Medtronic now. And we use a central catheter, with a central balloon catheter. Here you can see you can pass it. It's outside the balloon, unfortunately. And you burn proximally, and then you scrape everything off with the cap on top of it, and then burn again. So here you're left with a sort of a denuded mucosa. It goes around 0.5 millimeters depth, much less than you do with PDT, which goes around 2 to 5 millimeter depth. So you don't have the strictures that you do with photodynamic therapy. So after the first trial, this gentleman, he had a series of sequential photodynamic therapy. You can see he has a little bit of leftover. And this can be done through either an on top of the scope or now a through the scope, a 9-degree thumbnail application, and you can just touch up afterwards. Unfortunately, this requires around 3 to 4 episodes per patient, up to 8 centimeters. If it's more than 8 centimeters, it can go many more times sessions of photodynamic therapy. So this is the initial slide from Nick Shaheen. He's a good buddy of mine. I borrowed a few of his slides here, and I have to give him credit for that. As you can see, it got rid of the, it was able to get, compared to sham control using radiofrequency ablation, you're able to eliminate epithelial, intestinal metaplasia as well as dysplasia in the vast majority of patients. This is also durable. We see it both at progression in 1 year as well as later on at 3 years, that they're able to reduce the rate of progression to malignancy in patients with high-grade dysplasia from around 9 to 1%. Now, I recognize this. They also included non-dysplastic Barrett's as well as low-grade dysplasia. But I would sort of concentrate on the high-grade dysplasia because that's when it's most recognized indication. Now, again, this is a durable. This is a paper. This is a slide from Nick himself, showing at 5 years. We show that once you got rid of intestinal metaplasia, it's durable in both for both dysplasia as well as intestinal metaplasia in over 80% of the patients. So it seems to work long term. In addition, it can be used. It's in the real world. This is from the registry data, not from trial data. This is from you and me using this. It's easy to use, much easier than photodynamic therapy. Again, complete eradication at long term. It seems to be able to be used on registry data itself, so it is something that everyone can do. There are other ablative techniques. APC is very easy. Everyone has it. It's much, much, much cheaper than radiofrequency ablation. Good for very small foci. Also, more recently, Nick's been talking about using cryotherapy. This is a little bit more challenging. Initially, we have a centralizing balloon right now, but beforehand we used to have a free catheter, and the cryotherapy, the frozen compound expands extremely rapidly, resulting in lots of air, and I had to put a nasogastric tube in order to be able to tolerate it. Now there's a centralizing balloon. It reduces those symptoms. It can be used. It's a little bit more complicated and not as diffused as radiofrequency ablation, and has around the same efficacy, around 80% chance of getting rid of all of the dysplasia using cryotherapy. APC is much, much smaller for small foci, but it's quite good. The take-home message for ablation is that definitely you should use it for high-grade dysplasia. Low-grade, maybe. There's increased indication, at least in the United States and Canada. We tend not to use it for low-grade because it's quite expensive. And non-dysplastic, there is absolutely no reason to use it on 2% of the patient population. You'll run out of your entire hospital budget if you did it on everyone who has Barrett's, non-dysplastic Barrett's esophagus. Several modalities, photodynamic therapy, RFA, and cryo, and all of them are equally effective. However, radiofrequency ablation, because of the ease of use, as well as the efficacy, is by far the most common ablative therapy, although cryotherapy is coming along. So what are the problems with ablative therapies? The problem is some of them are if there's a large hiatal hernia or it's quite tortuous, it's hard to apply the centralizing balloon. In fact, we often repair these patients if they have a large hiatal hernia before doing radiofrequency ablation in order to get a long columnar esophagus or tubular esophagus that increase the efficacy of RFA. It does require multiple treatments, again, between 3 and 4, if it's less than 8 centimeters, many more if more than 8 centimeters, and very expensive. In Canada, it costs us around $10,000 per patient just in equipment costs. Forget about endoscopy costs, just in equipment costs. That's a lot of money, at least in Canada. It still requires close follow-up. Probably the biggest problem is that there's no pathology, and the concern is that you're painting over a potential cancer. So as we know that patients who have high-grade dysplasia, there's around a 50% discordance in pathology. They may actually develop with invasive malignancy. So how do you address that? Well, endoscopic resection. Anytime you see a mucosal abnormality or a nodule in the Barrett's has to be resected prior to radiofrequency ablation. 2 ways to do that. That's endoscopic mucosal resection or endoscopic submucosal dissection. I'll talk about those briefly. You can also have 2 outcomes from your endoscopic resection. It can either be diagnostic. If it's a cancer, it's a deep cancer, you can proceed with malignancy, or it can be therapeutic. If you have a patient who has a very short segment of Barrett's esophagus that's not circumferential, you can actually remove complete Barrett's excision, remove that completely, and save the patient a significant amount of return to the emergency for endoscopy suite. So it can be used for that or for malignancy. So what's EMR? Again, all endoscopic, all mucosal abnormalities and Barrett's has to be, that's the #1 take-home message, have to be resected endoscopically. The easiest one is by EMR. There's now 3 or 4 different ones that are available commercially. Basically, you create a pseudo polyp, and then you resect it. Here's an example of a small nodule from Mr. B that has a small nodule that's malignant. As you can see, you can suck it up into a cap, create a pseudo polyp, and resect it. You can continue doing this over again resect each piece adjacent to each other. You can get a large piece resected, but it can still, the problem with that is that it increases the rate of stricture and bleeding compared to the radiofrequency ablation, but also it removes the lesion piecemeal. So it's really good for small lesions in Barrett's esophagus. What about ESD? This is a bit more technically challenging. Use specialized techniques or tools through a regular gas scope. I started out doing this under general anesthesia. Now that my times have decreased, I do most of them in the endoscopy suite. However, for mid-esophageal, we tend to still do that under GA. So you can see, you can take a large piece, have a huge, also this is a gastric lesion that we did. It allows you to look at both circumferential and deep margins, so it has a decreased rate of recurrence, local regional recurrence compared to EMR. This is our experience we presented last year for Barrett's Neoplasia. We did 27 ESDs. It does take a lot longer than EMR, around an hour and a half, and length of stay is longer, clearly. So complications, they all bleed. There's 100% bleeding, but you're able to control that during the procedure itself. However, the perforation happened around 2 of those patients, and this is an example of a squame that we resected. Most of them can be managed endoscopically. You can see we resected a large amount of esophagus for a mid-third squame, and here you can see there's a small perforation. The patient's face is blowing up right now. You're able to place the clips on it and move on. And here you can see we just placed two endoscopic clips, and that controls it effectively. Those patients are admitted and kept MPO for a day or 2. Now that you've resected the lesion, what do you do with that? So this is a patient who has a Barrett's tumor, and we know that even in early malignancies, there's a rate of metastatic lymph nodes. So we've developed a normogram, combining over 250 patients from Canada, Germany, and the United States, and identified a normogram to help you guide whether or not you resect that patient with a serious esophagectomy, or you can ablate the rest of the Barrett's esophagus. So is that an endoscopic resection of a early cancer curative or not? Basically, look at size, depth, differentiation, and lymphovascular invasion, and based on that, you can come up with a scoring normogram. So let's put it all together. This is the last couple of slides. This is a gentleman we treated maybe a year and a half ago. As you can see, he has a large segment of Barrett's esophagus, 5 centimeters, not circumferential, but he has this nodular area here. So we start off by resecting the nodular area, and then ablate the rest of the esophagus. So here he goes. We mark out not the entire Barrett's, but just where the nodular area is. Performed endoscopic submucosal dissection. You can see this is the cap that pushes it away. The mucosa is here, the muscularis propria is here, and this is the IT2 knife. At the end of it, you end up with a large defect around 50% of the circumference. Final pathology is examined. Then you determine whether or not that's a curative resection of that cancer. So it's a early esophageal cancer, well differentiated, no lymphovascular invasion. The rate of lymph node metastasis in this gentleman is very low, so we can go ahead and ablate the rest of the Barrett's. If this was very high, then you would have a discussion with the patient whether or not you ablate or resect, do a formal esophagectomy. So here we have this gentleman prior to ESD. After ESD, you can see where the tumor was now a scar. We still have some Barrett's to ablate. We go in and just touch that up afterwards. And at 9 months, all he has is a little tongue, and we touch that up again with a radiofrequency ablation. So in summary, Barrett's is not the problem. It's actually protective. However, dysplasia is a problem. What are the ablative therapies? Who gets it? Basically, all patients with high-grade dysplasia and some with low-grade dysplasia. I would not recommend treating non-dysplastic Barrett's esophagus. Which modality? Right now, RFA is the most frequently used. However, there is some patients for it's useful to use APC or cryo or complete Barrett's excision. Endoscopic resection is both diagnostic versus therapeutic. EMR is technically facile, very easy to do. It's something that anyone in this room can do if you do any endoscopy. But its problem is it's only good for very small lesions. ESD for much bigger lesions, much more complicated. And pretty much what we're doing now for Barrett's esophagus is endoscopic resection either by ESD or EMR of the nodular areas and ablate the rest. Thank you very much.